Good morning and welcome to day 2 of the Big Sky Business Insight Summit. I'm Grant Kier, the President and CEO of the Missoula Economic Partnership. We really appreciate you joining us today. We had an outstanding day of content yesterday and we expect much of the same today. Today's focus will be navigating this pandemic through innovation, be a part of yesterday's activities. Just a quick summary. We heard from economist Bryce Ward. And Bryce shared some really thoughtful insights about what it takes to build a cluster, a successful industry cluster, anywhere really, and talked a lot about the nature of luck and serendipity in terms of creating those clusters. He used Seattle as a great example and Silicon Valley. He talked a little bit about Bill Gates simply liking Seattle and wanting to put his home there. And so he brought Microsoft there and founded it in Seattle, and it created this tech hub. In Silicon Valley, a very similar story where one of the early successful CEOs had simply moved back to Silicon Valley where he grew up to take care of a sick mother. And from that started this whole cluster of technology in that area as well. We heard from our panelists and experts and our governor that we really do have that same set of lucky circumstances in Montana. Obviously, this was an area that was known in the early days of settlement as being a place that was prone to Rocky Mountain spotted tick fever. And during that time, we, as a sort of serendipitous notion, we ended up with Rocky Mountain Labs, which has turned out to be an incredibly huge asset in COVID, but also delivered experts across the state in various fields of immunology and infectious disease. And McLaughlin Institute in Great Falls is another serendipitous story where just some really outstanding scientists in the field of bioscience happened to call Great Falls home, and they wanted to put that as a place that they grew up. So again, we have that similar story here in Montana that's helped be the seed of this really great bioscience cluster. But we also recognize through Bryce and some of our conversations that we have real challenges, and this summit was not just about patting ourselves on the back, but also about recognizing where we have challenges and how we can address them as we go forward. Bryce noted specifically that some of the challenges we face are just purely our size and our distribution of population. And really, typically where you find large industry clusters, especially in bioscience, tends to be in some of our bigger urban centers. Our panelists really talked, and our governor talked about this too, that we do a lot in Montana to overcome those challenges. This ethos that we have, that we are one small town with a long main street, I think really does bear fruit in terms of thinking of our cluster. And when we are able and willing to work across great distances, whether it's using technology like this or an old-fashioned phone call, to really capitalize on the network of people involved in bioscience across the state, we really do overcome some of that challenge that would otherwise appear on paper as a major detriment. But we heard story after story yesterday about how Montanans tend to come together to overcome challenges and find ways to communicate and work together. And nothing's really brought that out better than COVID in recent days. The other thing we talked about is we have quality over quantity here as a way that we overcome some of the challenges that Bryce discussed. Whether it was Robert Goodwin talking about the fact that in the early days of starting his company, it was pretty quick that investors and peers throughout the nation and the world realized quickly that although there were not a lot of people in Montana, the quality of work at his company and the quality of work coming out of the bioscience community was on par with anything else in the world. And that's certainly true of what we've seen evolve with GSK and other institutions. And we also make up for quality or quantity with quality on people. And we heard time and time again that we just see in our business leaders and our industry leaders and in the private sector that we have these amazing people who step up to big challenges, who are creative thinkers, and who are willing to work across interdisciplinary boundaries and geographic boundaries to really bring out the best in each other and push each other to do great things. I think we also talked about this quality of a Montana work ethic, but really we heard from industry leaders that they see that in the employees that they hire, and it helps them make the case for greater investment. It also helps them make the case to bring more talent into the state to help grow their companies. Of course, we've got work to do still. One of the people who has been instrumental in working with the Bioscience Alliance and industry leaders to recognize that we do have this cluster, and indeed to get federal recognition from the Small Business Administration, is Brigitte Miranda Freer. She is the director of the Montana World Trade Center and has been working as the lead on the Montana Bioscience Cluster Initiative. And we're going to hear a few words from her about sort of what she's been up to and the power of this cluster and what we're doing to continue to foster that. Brigitte, thanks for joining us.
Thanks, Grant. Well, in 2020, there are precious few things that any of us know with certainty, but what I can tell you is that the advent of this pandemic has underscored the need for a robust bioscience ecosystem in Montana and in this nation in a manner that can't be ignored. So while I can claim no prescient knowledge, it was indeed fortuitous that in 2018, Montana Bioscience Cluster Initiative was born as one of only 7 cluster cultivating proposals that was funded nationally by the SBA. So real nice recognition for Montana there. So let me share with you a thumbnail sketch of the initiative and our areas of focus. First, this is a coalition of organizations and individuals from across the state that are all aligned in supporting and expanding the bioscience ecosystem in Montana. There are several founding partners there. Montech, which is the technology incubator right across the river from UM. I also manage operations there. Montech is not only the prime contractor on this initiative, it's an essential physical asset in standing up bioscience firms in our state. It houses predominantly bioscience startups looking to commercialize technology, and it is currently filled to capacity. University of Montana is a key partner. UM provides not only funding for faculty and researchers capable of making these great scientific leaps forward, but also a continuum of support to help entrepreneurs and researchers wanting to commercialize technology, from startup ideation at Launchpad to business entity formation through SBDC, selling to the government through PTAC, and even selling internationally and making the case for foreign direct investment through Montana World Trade Center. Our friends at MEP are essential in engaging with the private sector so that we're not only meeting our existing workforce needs, but planning for workforce needs of tomorrow. Montana Bioscience Alliance is, of course, foundational to this initiative. I think Sharon Peterson there has almost single-handedly carried the torch for bioscience for well over a decade now. And finally, Swan Valley Medical is our private sector partner, and Ron there has played a key role in mentoring. So for your takeaways, Cluster Initiative work falls into 4 key buckets. 1, technical assistance and education that increases the probability of success. 2, understanding bioscience workforce needs and developing pathways to meet those needs. 3, messaging to the world about Montana's business case for bioscience. And 4, funding in the form of grants to assist bioscience startups, researchers, and entrepreneurs. So, even though we have precious little to be excited about these days, I hope you'll join me in being excited about this industry and what it means for Montana in terms of capital investment, job creation, and yes, maybe even being a part of the solution that helps make COVID-19 a thing of the past. Back to you, Grant.
Thank you, Brigitte. Thanks for your work. We're delighted to be a part of the partnership. So I'd like to share a story to tee up the next session here. When we were just coming out of lockdown, one of our hospital CEOs called me one evening to say, you know what, it looks like we may run out of viral test media, and we're struggling to figure out where to find it right now because there's so much demand across the country. And we were able to put in a few phone calls to local area biotech companies, one of which was Rocky Mountain Biologicals. And not only did they answer our call, but within hours, we were able to facilitate a conversation with our hospital CEOs, their company and their scientists and CEO to understand what the needs were, whether their capacity existed to produce it, and to use their network of supply chain across the country and across the world to have a viral test media produced and ready for use by our hospitals and then deployed across the state. I think that was done within a week or 8 days. It was incredible demonstration of our private sector stepping up to meet the needs of our community, completely changing the work that they did, a product that they had never produced before, but really innovative approach to responding to a need. And it also ended up opening a door for them to think about business opportunities in the future. It's really the spirit of the conversation today, how we're going to navigate this pandemic through our innovations. We have an incredible group of folks here today to talk about where we stand today with COVID. I'm here in Missoula, and we just recorded our highest incidence of new cases for a day. We're by no means out of the woods. We've got a lot of work to do, and I think this is not just a look back, but a look at what we can do next to make sure that we're bringing every resource to bear on how we navigate this COVID crisis going forward. So without further ado, I'm going to introduce our moderator for today's panel, Avery Sonnenberg. Avery is a principal at Two Bear Capital. He has a PhD in bioengineering and came from the private sector to join Two Bear here in Montana and to help reach out to biotech companies from across the state. I'll let Avery turn it over to the panelists to make introductions. Avery, thank you so much for being here and joining us today, and thank you for being a part of Two Bear Capital. We're delighted to have him in Montana.
Thanks, Grant. We're super happy to be in Montana. That was a great introduction. So, as Grant said, I think, and I agree, as a new Montanan, I've only lived in Montana for about 5 months now, but I'm already loving it. Montana does have a rich history of being creative problem solvers. And as we saw yesterday, I think this culture definitely exists in our bioscience, biotech, and healthcare communities. So I'm excited today to help facilitate a discussion that will allow us to sort of share the state of the pandemic in Montana, look at some of the creative solutions that we've come up with to address it, but also look at some of the unmet needs and the challenges that we still face. So if the panelists want to go ahead and turn on their videos, I'm going to briefly introduce them, and then we'll get right into the discussion. So let's see. I'll try to do this in the order that I may ask them to speak. So Delila Bruno is here. She's the administrator of the Disaster and Emergency Services Division for the state of Montana, and she's been doing that since 2015. During her time in that position, the state has faced lots of different kinds of disasters, from storms, tornadoes, flooding, drought, fires, and most recently, obviously, the COVID-19 pandemic. And she previously managed the Public Health Emergency Preparedness Program at the Department of Public Health and Human Services, and she works closely at the state level to manage the response there. Dr. Neil Koo is with the Billings Clinic. He currently serves as the hospital epidemiologist and also the medical director of infection prevention and control and microbial stewardship. And he's also the chair of the infectious disease group at the Billings Clinic. So infectious disease, infection prevention and control, I imagine you're pretty busy these days. So we'll be getting some of your thoughts on your experience and what we may be able to do in the future to help control the spread of this virus. Scott Whittenburg is the Vice President for Research and Creative Scholarship at University of Montana. And we also have Dr. Blake Wiedenheft, who's an Associate Professor at Montana State University. His PhD was from Montana State. He, very interestingly, at least to me, was working on isolating viruses from the boiling acid environments of Yellowstone National Park. After that, he went to UC Berkeley to work in Jennifer Doudna's lab, pursuing molecular mechanisms within bacteria, which you may have heard of, called CRISPR. You may also, if you've been following the announcement of the Nobel Prizes, notice that the leader of that lab, Jennifer Doudna, that he worked with, and he was instrumental in that project, shared the Nobel Prize in Chemistry this morning for those developments. So that's very impressive, and congratulations to her and also to you, Blake, for your part in that. So, as we go through these questions, I want to focus on celebrating some of the successes that we've had as a state, the things that we're doing that are working in our response, maybe some of the unique attributes that Montana has that let us do some things more quickly or differently than other states in a beneficial way. Maybe focus on some of the things that Grant was alluding to with the collaboration with the hospitals and Rocky Mountain Biologicals. So that's communications and solutions that we've come up with public-private partnerships. But I also want to focus on trying to identify the gaps in knowledge, technology, supply issues, and other opportunities that still exist for innovation, right? And don't forget, this is to the panelists, that in your answers, this is also your chance to expose people in the audience to whatever you have as your most sort of acute, ongoing critical need. So this is also a problem-solving session potentially too, as you give this information. So the focus and the title of the discussion is Navigating a Pandemic Through Innovation. So Delila, this question is going to go to you. As the person on the panel perhaps closest to the navigation part of this, could you provide us with kind of your high level of experience of the pandemic, Montana's response, and also things that people may not be aware of? And I'm speaking about the various forces pulling at sort of the steering wheel in this navigation analogy, including our federal partners and how kind of the answers may have changed over time from March up until the present.
Sure. Well, thank you very much for the opportunity to be here. I had a phone call from Major General Quinn this morning at about 8 o'clock, who was scheduled to be here with you today. Unfortunately, he was delayed receiving some troops back from a year-long deployment from overseas. So I'm thrilled to be here in his place, and he's definitely sends his regrets. I think from a disaster management perspective, there's been a lot of unique challenges with the COVID-19, and the first one really is the duration of a pandemic. Early on in this, there was the task force was pulled together with a lot of different backgrounds, trying to figure out how they could be problem solvers to this situation that we knew was going to unfold over weeks, months, and potentially as long as a year or more. And so we had some areas of focus that we really brought to the forefront that had to do with trying to slow that spread and contain that spread of the disease, and informing people what that really meant. Developing a testing strategy that made sense for Montana, which had its ups and downs, and I can talk a little bit about, and then just making sure that we were prepared for that future surge. As we, probably saw the spike in the spring, we knew it would level off, and then we kind of didn't know how bad it was going to get down here in the late summer and early fall and into the winter. So with that, the slow the spreads part, look, we had to lean into experts around the state. As an emergency manager, as somebody in the Department of Military Affairs, that's not our background. We're typically called out to, deal with wildfire management or, flooding disaster, recovering from that kind of a thing. So it was new territory for us that we had to make sure that we were definitely able to adapt and evolve some of the practices that we're used to this situation. As far as developing a testing strategy goes, that has been a very big piece of what the task force and DES and DMA, what we've been working on. When we started out in March timeframe, the Montana Public Health Lab, they were turning through about 200 COVID tests a day. And that was with an incredible amount of dedication and just hard work from folks in that lab, diligently processing CAPA 200. After much internal kind of evaluation and improved equipment and things that they were able to do, we're up to 1,200 tests a day being processed in the Montana Public Health Lab. But yet early on, again, we knew that wasn't going to be enough. We knew we had to continue to build capacity, and that's where we really looked out to the business community and what kind of contracts we could put in place for overflow. We weren't alone in that thought process, and the rest of the nation also went after these contractors and who could help out for testing. And we got into a contract with one lab that they were getting hit from every different direction, and all of a sudden we saw some issues with our turnaround time. Trying to get rapid test results back to people, our turnaround times grew and grew and grew and grew, upwards of 2 weeks in the middle of the summer for folks. So again, remembering that we had to adapt, we had to overcome, we had to figure out how we could accomplish this task differently. We turned back to the state and a lot of our partners internally and said, what can we do inside Montana and build capacity here? And thanks to some wonderful partnerships with the Montana State University and other contractors that we were able to partner with, we're finally back to a place where we feel comfortable, where priority testing is. By priority testing, I mean people who are ill or contacts ill people. They're getting their results between 24 and 48 hours. Those asymptomatic kind of cautionary tests or just lower priority tests, they're still taken between 3 and 5 days, but we're definitely in a much better position than we were, and our capacity is much better than it was in the spring, and that's saying something for the creative efforts to move forward from our partners. The third aspect, so slowing the spread, having our testing plan put in place. The third part being thinking of what the future surge in the demand is going to be. We've really put a lot of attention on what the fall could look like and how challenging it was in the spring to find the right personal protective equipment and supplies for our communities, for our hospitals. Everybody was chasing the same vendors. It was really the Wild West as far as trying to find supplies and resources. A lot of fraud taking place, a lot of price gouging, very difficult. Fortunately, we are seeing some stabilization in that, in those supply chains. Things are getting a little bit more easy to find. From a state side, what we've tried to do is make sure that we have a cache here of medical supplies that are able to be pushed out to local governments, local hospitals, community health centers, if need be. And then we've also tried to forward place some of those supplies for emergency use as well. So, I guess I'd just say that, as our task force, as our team has looked at this, we've said nothing is off the table as we try to figure out how to simultaneously run through, slowing that spread to keeping our testing current, keeping our eye on the future. If we need to borrow something, build something, buy something, repurpose something, we will. It's just keeping up with the demand and the changing needs of our state and our communities has been something we've always tried to keep at the forefront. So that's where I'm at there. So,
and then looking towards the future, trying to manage all of these various risks and aspects of the pandemic, what would you say is maybe the biggest unmet need or the thing that you're maybe furthest from a solution on going forward in time, maybe 3 to 6 months?
Sure. So great question. And I'd say right now what we're seeing is an uptick and a shortage in people. And it really is that medical community, registered nurses especially. We get, it's not just our hospitals, which obviously have their need for their personnel, but it's our community health, our nursing homes and long-term care facilities, our nurses that support congregate living spaces. When those folks are out of the fold, whether they're sick or quarantined, it puts a strain on everybody. So we are seeing an uptake in those requests and not a very deep pool of people we're able to pull from. And that's not just a problem to Montana, that's nationwide.
Yeah, that's, I think, a similar thing I've heard from a lot of people. One of our Two Bear Capital portfolio companies, Fire Diagnostics, is working on their ability to offer testing to the Montana population. And again, that's, Montana will be their priority because they're a Montana company, right? So you're not going to get your 2-week turnaround time. But their biggest bottleneck right now, their biggest ability to scale their testing is absolutely people. They can buy fancy liquid handling machines, and even if the lead times are long, the biggest problem is having qualified people that have the credentials that are required by the Clia lab certification protocols to be able to run those high complexity tests. So it's definitely a need that I think we should keep track of and try to work together to come up with solutions for.
Avery, I think another national challenge is the turnaround times. They continue to be a problem around the country. I mean, Montana's not unique in that regard either. And I think what's becoming increasingly evident is that we need quicker turnaround times. The assays themselves don't need to be so sensitive per se, but they need to be quick to get the information to the patients. And I think that's a really important space for innovation. And I think Fire and other companies here in Montana are working to address that need.
Yeah, absolutely. The turnaround time is absolutely critical. If you can't get your test for 5 to 9 days, if you can't get your result, then you should be self-isolating. And if it's your child maybe that's getting tested, then they have to be out of school and you have to be home. So there's a big sort of economic hit just from that lag time.
Lag time, maybe a related issue is that given the prevalence of asymptomatic spreaders, even people who are asymptomatic should be getting tested with regular frequency so that they can be eliminated from the problem pool from spreading the disease, even if they're not exhibiting symptoms themselves.
Okay, I guess, Scott, you have a comment about that?
Yeah, I can add two things. I agree 100% with what Blake just said. I think we really need to expand our asymptomatic testing. I realize the need to do the symptomatic testing, but we need to catch people before they become the super spreaders. The other piece I would add to this is, I don't know if Delila knows, but we converted our genomics core here at the University of Montana into a Clia certified testing facility for the state. And that's something that I think we can also do at MSU Billings as well. I know that moves afoot. And so I think that's another resource that the state has that we need to expand on, and that is these research universities that already have PCR-based instruments here and other testing facilities that we can use and do hundreds of tests a day as well at these facilities. So I think that's an asset that, at least for the next pandemic, we need to sort of build upon. And as you said, Avery, it's the Clia certification process that becomes part of the slowness in that. We got a lot of assistance from Michelle at the state level on getting our Clia certification. So that was actually a very good process here in Montana, was getting that certification. But finding the right people that have those certifications is one of the tricky parts for this process.
And that's definitely one of the interesting things for me. So converting the genomics core is a wonderful idea, because people may not realize that these research-grade instruments that exist in molecular biology labs, these are the same instruments that we use for these diagnostic tests. The sort of expertise that you need to either create or validate a nucleic acid test, like a PCR test for a virus or bacterial organism, it's the same expertise that these professors have. So you can easily sort of, see the crossover, and then the problem becomes, at some point the regulation, and then the throughput, how you can manage your lab to do the throughput. Scott, do you have a sense of how many tests the genomics core will be able to handle a day once it's fully converted?
Well, actually, it's probably unlimited, because you can always add more PCR instruments, more robots, and so on as the demand increases. So we're going to start off at 80 a day for the
80 tests a day.
But we know we can easily get to 200 a day without any problems.
Okay, up to 200. Yeah, and then you can add machines, but at some point, it's a matter of maybe it's 4 months to get that machine. So that's why it's a big advantage to be able to take machines that already exist in the genomics core, and even something like 80 tests a day definitely helps move the needle.
Yeah, we're less people. I'm sorry, I'm talking too much, but we're less people constrained because we have graduate students and postdocs and others that already have some familiarity with the instruments. So I think less people, but certainly the Clia part was the slow step for us.
Yeah, and it's I'm not exactly familiar with how to transfer those credentials. I know if you have enough experience handling biological materials, you can sort of transfer those credentials potentially into a certification for high complexity testing. But yeah, the people, for different groups, the different constraints are there. But people who can run the high complexity testing is still an issue. And then even beyond that, it's reporting. How do you report these results in a compliant way if you have personal, health information that you can't allow access to, and you have to keep tight control of that for HIPAA reasons.
Hey, Avery, one anecdote from Bozeman that might speak to some of what you're discussing now is that I think that we had an interesting partnership with Bozeman Health in the beginning that kind of highlights this disconnect between Clia and the expertise that's at every university that you were mentioning. I mean, we had a perfect collaboration in my mind with Bozeman Health, because what they had, we didn't have, and vice versa. We had the expertise, we had the equipment, we had the know-how to perform all of these molecular tests, but what we didn't have was access to samples and to sick people, and the certifications and the HIPAA regulations and all of those sorts of things. So the partnership with Bozeman Health was one that was, I think, really well conceived and worked quite well. They had access to all those sick people and the regulatory infrastructure to support that. So the partnership worked, that we brought the training, the equipment, and the expertise to help train people at Bozeman, people in the testing facility at Bozeman Health, and stand up a testing facility there for testing SARS coronavirus using the gold standard quantitative PCR. And once the training was done, and a lot of the training was done by Michelle Flinick and a colleague of mine here at MSU, of people there at the hospital, once that was done, then they could operate independently. And I think they have been for several months now. And I don't know what their capacity at this point is, but they do have a little bit of a reaching into the talent pool, as we were kind of discussing earlier, and finding enough qualified people to do that. I'm not an expert on Clia certifications, nor am I familiar enough with those regulations. Maybe Dr. Koo could speak to this a little bit, but my understanding is that if you have the expertise to perform the test, that's sufficient so long as somebody who is Clia certified does the data entry and data analysis.
Yeah, I think that's really smart to try to look for somebody who has all the pieces that you can't do and put those things together. So that's definitely interesting.
This is Neil Koo. So, well, let me chime in on that real quick, and I'll circle back to some of the comments about more testing in general. So, certainly all the tests that we have available let me step back. There are no FDA approved tests for SARS-CoV-2 detection. There's no. So, and I think that and there have been some confusion as such, but all these tests that's available commercially, or that's been put together by university labs and such, have received the emergency use authorization. So a lot of these and that kind of lighten a lot of the burden of meeting a lot of the criteria for the use of these tests. And this is mostly came as a result of that when the CDC was the only place that did the SARS-CoV-2 testing, and then they had the issues with the reagents that opened up. They couldn't fix the problem in time, and we had mounting cases of suspected of COVID-19. That they opened up this to allow this testing for other test developers to make their own tests, as well as like commercial laboratories such as LabCorp and Quest. Now, so the regulation. Now, I'm not sure that there's still going to be some regulation, but there wouldn't be as much of having to jump through a lot of hoops and such to get to meet that certification. Now, I don't have the specific details. That's actually pathology knows more about that than I do. But in general, it is not as stringent. Now, I do want to kind of circle back a little bit on the discussion about testing in general, because this has been a discussion amongst epidemiologists. And there's a lot of different views and epidemiologists across the country, and a lot of this is because there is some, one is testing has always been an issue because the case definition of COVID-19 is almost exclusively based on a test result. So it's not most of the time, it's not a clinical diagnosis. Is that anyone who gets tested positive with SARS-CoV-2 is determined to have COVID-19. And I think that's part of what it kind of created a lot of this, increase in testing, at least partly, is because that's the only way you can make the diagnosis. And unfortunately, that case definition is really an epidemiologic case definition, not as much of a clinical definition. Unfortunately, we kind of stuck with that. Now, as in the beginning, we were really focusing on testing those patients with epidemiologic risk factors, such as travel from China, Wuhan, China, or a contact history, someone who have been in contact with someone known to have or clinically have COVID-19. As that kind of came about, I think that it was really that the Princess Diamond of the cruise ship that really led to the suspicion about asymptomatic infections, because at that time, when the CDC were reviewing, doing all the evaluation of all the passengers, they tested everybody. Now, and that's kind of where they found a number of those. I think it was about somewhere around 40% of those passengers had exhibited no symptoms. Now, one of and that kind of led to a lot of these other kind of evaluating other other studies that kind of started discussing more and more about the asymptomatic carriage and what the significance is. And this was a huge discussion and unfortunately also created a little bit of hysteria because, is my neighbor infected? Should I be next to him? Should I be around anyone? And so that kind of that started flooding into a lot of the news media as well as the medical literature. the challenge with asymptomatic carriage is that there are not a lot of studies on them, because it's not, and because at that time we couldn't test everybody because we didn't have all the tests available. And a lot of and so, there are some places, smaller, have done testing of everyone in smaller populations, but in general, we just don't have that data. I think the largest data that looked at possible asymptomatic carriage, it was really was done in, I believe, in California, in LA, where they use serologic testing, not the test, rather than the PCR-based test that we are more commonly associated with. And they did they tested those patients, those persons, and then asked if they have had symptoms and such, and that's kind of how they derived the numbers. Now, back then, there were the limitation of those studies is that they focus on very narrow number of symptoms, because at that time the recognized symptoms of COVID-19 was fever, shortness of breath, and cough. And as you probably know, now as we go along, we have new symptoms have evolved that's been identified. Probably the one that most people now have been kind of talked about is the nausea, which is the loss of smell, and then dysgeusia, which is the loss of taste. And then there are other symptoms such as the COVID toes. That, I saw that on news and such. So, as well as and some GI symptoms, diarrhea, nausea, vomiting, and diarrhea. So now, and so it would be interesting to kind of see what the prevalence of asymptomatic, those who have been really truly are asymptomatic, because now we have a lot more symptoms to include, and to go back and see if maybe they were symptomatic, they're not truly asymptomatic. Now, the discussion but unfortunately, the impact of this concept of asymptomatic carriage has actually made a huge impact on the testing capacity of many institutions, including ours, because there's probably one of the biggest percentage of testing that's performed at the Billings Clinic is actually on asymptomatic persons for procedures that's being elective procedures that's being scheduled ahead now, the upcoming procedures, as well as anyone who comes into the hospital without for urgent emergent procedures, who will he needs to go to the OR really or have a procedure like endoscopy performed. The reasoning for that has ranged from from the protecting our healthcare workers, because if they are to be intubated, they're going to undergo if they're going to be intubated, there's concerns that could be an aerosol generating medical procedure, right, to other things. I said concerns about potential complications associated with COVID-19, and so there's been some observational reports coming out of China that said about 20% of patients who underwent a surgical procedure will end up experiencing complications that result in mortality. So there's a lot. So what I'm getting at is that the drive for testing is not just all these identifying those patients who are symptomatic and have COVID-19, but it has expanded out to now pre-procedural testing, and then the discussion about surveillance and that how that goes, and that certainly trying to do surveillance testing is use a lot of tests. Unfortunately, looking at these asymptomatic persons and surveillance, at least in Montana, the percentage of actually asymptomatic that doing surveillance testing and the pre-procedural testing, the percentage of patients who actually have identified to have COVID-19 is very low. Our pre-procedural testing, it's about 0.8%. That's less than 1% of our population coming in asymptomatic, got tested, who's going to present, is very, very low. But despite that has driven the need to test, it didn't deter any desire to test less. It's actually because of all the other situations, usually the isolated case of someone didn't get identified, that drives testing more. So there's a lot of confounding factors. Now, part of the reason I'm bringing this up is because this has a huge impact on not just healthcare workers, the shortage, but also our economy, because someone gets tested positive, they're asymptomatic, they automatically go into quarantine, and so they can't work. And that is kind of where one of the biggest challenge that we at public health here, especially here in Yellowstone County, having to deal with is we have now a sizable number of people who have these symptoms. Either they're either they've been tested positive, or they're, which is legitimate, or they're asymptomatic, but they're been exposed. That's kind of where we're affecting a lot of our workforce. So really, now that we're 9 months into this pandemic, my really say is isn't so much the what we hear on the news, test, but more smarter testing. And looking at what will make the most impact, because I don't think that in the near future that even though we're looking at different ways of trying to increase our testing capacity, that we're going to be able to get to the goal of that ability to test everyone that we want. And then there's other issues about
there's absolutely other kind of pressing things that push on the decision making one way or other with testing, right? So I don't know what somebody will figure out what the best use of the available tests is and what the optimum capacity is. But I don't think anybody would argue right now that we're there yet in terms of the testing capacity. So I think everything we can do to increase the testing capacity, at least at this point, will only help. So there's other things that actually this is a good segue to you, Blake. There's other things that you've been involved in that your group has been looking at. Could you talk maybe a little bit about the wastewater testing and what that is? Maybe people aren't familiar with that. And then maybe some of the issues or ideas for doing at-home testing.
Sure. I think in terms of testing, it has to be a full court press. And we have to take advantage of every opportunity that we can. And wastewater presented an early opportunity. I think if you look at the distribution of the ACE2 receptor, this is the receptor that's recognized by the virus, it's highly expressed in the GI system. And early on in the pandemic, it was recognized that the virus was actually identifiable in feces. So that led to this hypothesis that the virus would be detectable in wastewater. And it was also true for SARS-CoV-1. So maybe this wasn't completely innovative, but several labs, including my own, early in the pandemic went to the wastewater to start sampling the wastewater for SARS coronavirus. And it was a little bit of, I initially did it myself on a whim, drove down to the wastewater treatment plant, and I was a little bit skeptical, thinking that I might be wasting my time by, taking a dipstick. It's really a painter stick with something the size of a coffee cup on the end, and dipping it into a pipe that's coming into the wastewater treatment plant that's processing over 6 million gallons of wastewater every day. So it felt like a bit of a long shot that we would really be able to detect the virus in such a diluted sample. But when we did, we were surprised and maybe a touch alarmed that there was detectable levels of SARS coronavirus in a community like Bozeman in the wastewater. So after that initial experience, we established a little bit more of a rigorous protocol where we would use an auto sampler that takes a sample of the wastewater every hour for a 24-hour period, kind of getting a collective average of the community's contribution. And then we would bring those samples back to the lab. And in the beginning, we had some concerns about biosafety. How are we going to handle these samples in a way that wouldn't endanger people in the lab? But we quickly learned, and in collaboration with the research compliance office here and some of the biosafety officers, how to handle those samples safely, initially using N95s and biosafety cabinets. But of course, there were shortages with PPE, so we were looking for ways to get around or to subvert the requirement for some of that PPE. And so we started pasteurizing the samples, just heating them to 65 degrees for about an hour. The virus is no longer infectious after that kind of period. So then we could pull them out of the biosafety cabinet and work with them on the bench. It really accelerated the rate of our research. Then there's a number of different procedures that are used now to concentrate virus from wastewater, and then we apply the same diagnostic test, the quantitative PCR test that a patient would get, to the sample that came from the wastewater. And what we learned in the course of that, but in a paper that we recently published in Cell Reports Medicine, we showed that wastewater testing is one of the most powerful real-time indicators of a coming surge. And in fact, we see a spike in wastewater 2 days before it's noticed by the state or clinical testing laboratories. So I think if you really want a cost-effective, rapid, real-time testing modality where you don't have problems with compliance, wastewater is a really powerful tool that should be incorporated into the full court press that we're bringing to bear on this problem. I think it's something that hasn't been fully reached the leadership, and I think it's an important aspect to consider going forward.
Can I just add to that? Yes, I realize that MSU Billings is also looking at doing wastewater testing over there, and they've done some already, as have we at the University of Montana. And our other thing we would add to that is we already do eDNA up at Flathead Lake, in which we do real-time monitoring for zebra mussels, and that can easily be converted into doing the RNA to look in wastewater for COVID and other viruses here as well.
That's super interesting. It's especially interesting that you can detect it earlier, Blake, than potentially the surge would be noticed. Is there any sense, and maybe this is a Dr. Koo question too, is there any sense as to if the virus is replicating in large numbers within the GI tract and being expelled into the wastewater prior to somebody being symptomatic, or even in the case where they're asymptomatic?
Well, so that's a very good question. And most of the studies on SARS-CoV-2 is really on the upper respiratory tract, So yes, there's been some studies that confirm that there are some that we can. Let me rephrase that SARS-CoV-2 has been our DNA RNA has been detected in stool. The challenge with this is, and I'm thinking through more of a public health and epidemiologic standpoint, is that this would be a good test to determine if you have disease in the community. But what the problem is that in communities that have the disease already, it may not be it may not be as helpful. And because it's not telling you what are you already know. So more than that. And so the scenarios I can kind of imagine is that, yes, if you're waiting to look for, detect this in a community that hadn't had any cases or very, very few cases, it may be something to help to identify surge or as an indicator to see if it's improved, if a community is coming out of that. The challenge is that if it's done in a community with active circulation, who do you search? Do you screen? And maybe this is a discussion on then deciding that these are the community to do the surveillance testing. However, this is a challenge. It's going back to is about public health. Is one of our biggest shortage is not just only healthcare workers, but also public health. Those who work in public health, and to do all the contact investigations. And so we have to solve that problem. In addition to trying to detect these, if there are going to be higher upsurge in cases of COVID-19, because this is only part of the solution. If we cannot get enough people to do this contact investigation, the virus will continue to spread, because that's actually what we do as part of our intervention, is to identify those, to isolate them. Now, this has been discussed a little bit in the epidemiologist community, but it's just the utility of it is a little challenging. It may have been a great thing early on in the pandemic. Right now, it's becoming more common. That's where we're trying to figure out how could this be useful.
I think the utility has been pretty well demonstrated. I mean, I think that the intention of the tool isn't to ask who's infected, but to ask about community-wide surveillance. So if tools or if tests are in short use, then like you mentioned earlier, it's maybe not the most prudent way to do widespread testing in a community where there's no evidence of the disease. However, a lot of people are asymptomatic, and moreover, almost everybody's asymptomatic before they're symptomatic. So they can be shedding the virus before you even know that people are infected, and everybody's contributing to the waste stream. So what we've shown is that you can detect an early or a coming surge by monitoring wastewater. And then moreover, when Governor Bullock enforced the shelter-in-place order, what we saw is that there was a commensurate downturn in the amount of virus that we were seeing in the wastewater that corresponded to the shelter-in-place order. So we can monitor how public measures and policy is having an impact in a given community, and I think that the impact of that can't be understated or overstated.
So then maybe that leads into a question for Delila. If you had this sort of in place, what would be the plan if you had widespread wastewater monitoring in place? What kind of actions could leadership take after they see a spike?
Right, and I think that Dr. Koo actually kind of hit it. I think we've wrestled with this at the state level, task force level now for some months of what's the next step? What do you do with the information? And again, it's also there's an aspect of community fatigue with this. They go to the map every day. They see how many cases. They're going to look on the map today and see there's 733 new cases. And we have a hard time trying to modify behavior, even with the reality of today's our highest day out there. Taking something like wastewater testing and say, yeah, we found this. We know it's in your wastewater area. What's the next step that modifies human behavior? Or what's the next thing that next level of testing that can be done? I think we wrestle with that. Just thinking off the cuff here as we're going through this, I think maybe a more targeted approach to wastewater right down to like facilities, congregate settings, maybe, again, I think of our most vulnerable settings, our nursing homes, our facilities, assisted living. If there was a way to target something so then you could apply an action before something gets too far out of hand to a small subset of people, that might be something that would be more palatable. But from that big community perspective, I think there's a lot of social dynamics that play into it, and then kind of challenges of just how do you get your arms around it? What's it telling us it's actionable? That's just been a challenge we've been wrestling with.
Yeah, can I jump in there? Because that was sort of what I was going to allude to, is the definition of community. Because if you think of a community as the entire city, then I'm not sure how valuable that information is. But like on our campus, if we do it for a dorm and we can identify early on that it's within a dorm, then we can do a pooled sample or other approach, a sentinel testing within that segment. So like Delila says, if you do it for wastewater for nursing homes or whatever, and get an early warning for a nursing home, then you can do something about it. So it's an early sentinel testing that allows you to, but you have to find what the community is.
I think your metaphor is perfect, but community can be defined at many different levels. And if there's a community that's negative, but suddenly you see that there's a spike in wastewater that you're not picking up by other epidemiological indicators, then I think that's an important understanding to have, that there is evidence of the virus in a particular community that people are unaware of, and that information might help change their behavior. Moreover, if you use wastewater testing to do just what you said, and there's plenty of evidence out there to demonstrate that it's really valuable to do point of release testing. So if we do wastewater testing at the Bozeman Wastewater Reclamation Facility, and we know that there's certain trending indications happening here in Bozeman, and then we back that up to certain facilities like MSU. So monitoring the tube that leaves MSU, but then backing it up even further to the individual dorms, it's been demonstrated that then you can isolate a dorm or a particular large capacity housing facility to minimize the impact of the spread from that point.
Actually, you kind of bring up an issue, a point that is probably one of the biggest challenge I have, is that as you're kind of, if that is going to be our mitigation strategy to isolate a entire area, a group of people, it's no easy feat. I'm just gonna tell you, because and that's one of the hardest thing we have to deal with public health is that the more people you isolate, it's just hard by itself, because our compliance just to get people to stay, I'm not talking about those with symptoms and diagnosed with COVID-19, but those who are supposed to be quarantined, our compliance rate is very low. So yes, and I'm tying these together as we're kind of coming up with these ideas of how are we going to detect cases. We have to come up with just as important is to come up with ideas of how we're going to react to this. Otherwise, doing the testing, just like all the information, if you don't know what to do with it, it will fail. And that's one of I will kind of emphasize here in this.
Well, there's a difference between knowing what you're supposed to do with the testing
and that's
information and doing what you're supposed to do with the testing information.
And even though we're talking about testing is part of the issue. We have to come up with a better strategy with getting the community, our public, to go and to be willingly to go comply with all of our mitigation strategies. And the final thing I want to point out is that we've been always looking at, and there's a lot of people looking at using tests as a preventative action. But the truth is, it's not the same as like wearing a mask or physical distancing. And I know that and it's really to our early identification of those cases where we would then get those isolated so that it will that person will not infect others. Instead of protecting others, you can make that argument. But truth is,
and so in that vein, what can we do to improve the contact tracing? And this kind of gets into the questions that are coming in the chat here. This is one of them. What can we do to improve contact tracing? Is there something like an app that we could get all Montanans to download that would, give access to your GPS data or something like that to let you know who you've been in contact with?
That's a very good question, and I think no one has the perfect answer for it. At least none of the epidemiologists I spoke to. I think the biggest concern is privacy issues. If if we're going to put an app, will they willingly put that information on, and to let others around them know? I know that at the latest, iOS update actually allows that, and I question how effective that is because, especially my experience with Montanans, and I've just been here for a little over a year, I've noticed about how they react to certain things like this. Is definitely not the same as other parts of the country. And I don't know if we even think if this is a good idea to make it mandatory. If someone has COVID-19, should they be tracked? Now we haven't gotten that far, and then finally is how do we enforce that? Even if we said this is mandatory, So there's a lot of more challenges. Right. It's not just the testing component now; it's all these other things that we're trying to do to make sure that people are doing the thing they should be doing.
It's possible that people that are not compliant with one of these aspects would be universally non-compliant with some of the other ones. I want to dive into more of these questions to try to get through them. So someone's asking, for a technician to work in a Clia lab, what certifications do they need in addition to their degree? My understanding is that it's a medical technician or medical lab technologist certification. And a lot of I think some of the 2 and 4 year programs that are designed to lead into these jobs actually build some of the training requirements for those certifications into the degree program, such that you don't have to spend additional time after the degree program getting that. In addition, in terms of the wastewater testing, Blake, do you know if it has to be a BSL-2 or BSL-3 facility? I suspect it's probably just BSL-2.
Yeah, like I was saying before, especially if you pasteurize the sample, there's considerably less risk, and a BSL-2 is sufficient from my understanding of the regulations. I also noticed a question on the chat about where to get access to that information, and at least all the information that we've collected here in Bozeman is available at the Gallatin County Health Department's website. If you just Google the County Health Department and wastewater, you can find a live tracking of wastewater testing that's happening in and around Bozeman, and we plot that weekly with superimposed on top of the epidemiological data. So this early warning indications that I was discussing earlier, you can see that in real time now on the Gallatin County website. It's not exactly comparing apples to apples to compare wastewater from one place to another, though, and I think that's an important thing to bring up. Although the test is performed identically, meaning the PCR, the processing of the wastewater itself is done differently between different labs and different volumes are used. So it's not exactly comparing apples to apples, so just something to be aware of.
Would it be possible to expand the wastewater testing outside? I know you do it in Bozeman, but have you thought about expanding it outside to other cities in Montana?
Yeah, there's been considerable interest. I mean, it's maybe not a daily occurrence, but at least several times a week I'm contacted by city officials from all over Montana, but all over the country, really. We recently had an article that was published in the Atlantic that covered the work that we've been doing here in Bozeman, discussing wastewater testing, and now certain governments have moved into funding wastewater testing efforts across the country because of their recognized value in controlling the pandemic.
Can I give one clarification? I'm far from an expert in this, but there's a distinction between what's needed to be get Clia certification versus the certification that you need to actually work in the lab. The certification to work in the lab actually comes from the Department of Labor and Industry, and that one actually has a whole range of qualifications you can have to get that kind of certification.
Is there anything that could be done legislatively at the state level to relax those requirements in light of the shortage of that kind of certification presently?
I think it's more just, we have a joint degree program that's between us and MSU and maybe others. I'm aware of these two institutions working on it. And I think it's just getting more people into that program. And the other key is clinical sites, because they have to have clinical sites that they work at, and the number of clinical sites in the state is not sufficient to build up that workforce.
Okay.
I think there are some administrative things to be done. I know that my former advisor in Berkeley was part of a team that helped with the governor's support waive Clia certification in California, and they were early to move into high throughput testing by employing expertise in infrastructure at the universities around the Bay Area, at least. This afternoon, I'm running a class right now, or teaching a class right now that's, in fact, the students are testing their own saliva for SARS-CoV-2 using the quantitative PCR tests. And I suspect that that's happening around the country, really, where that is being brought into the curriculum, where students really understand these tests at a higher level. And I think as a land-grant institution, that's an important message to get out there, that it's really our job to deliver the on-the-job training, so to speak, to these students, to give them the skills that make them relevant in the contemporary workforce. And I think that's part of the mission of the universities, and is certainly one of my own priorities.
And I guess optimistically, I would hope that this pandemic will lead to a wave of people interested in biosciences and life sciences career options at all levels. Is there anything at either MSU or U of M that lets you think that?
I also teach virology, and I'll say that there's never been more interest in virology. So it's kind of exciting times for virologists to have so much interest in something that was previously thought to be a little bit more of a boutique field. That
we're gonna talk more about that a little later, Blake. Definitely.
All right.
Our college
virology is cool again.
Yeah, our College of Health is, of course, we have a new Center for Public Health, which also, and a new degree program on that as well. So there's a big demand for it.
That's great. Well, I guess we need to prepare to handle that and take advantage of that surge of interest for sure. All right. So part of the goal of this was to identify our sort of unmet needs and things that we can come up with solutions to, in addition to sort of identify some of the creative solutions that have already been implemented. Does anybody else have a critical unmet need that they want to expose the audience to, that in a way that may help you find a solution?
We discussed this a little bit before, but I think one of the unmet needs around the country is the rapid and frequent testing and scalable technologies that could be used on a daily basis. Because of this time to exposure to time that you're actually symptomatic, and that's a dangerous period because viral titers are high, and so you're spreading, it emphasizes the critical nature of frequent and rapid test results. And I think that there's really a lot of room for innovation there, and there's several companies here in Montana that are attempting to address that. And I think, a lot of the discussion that's happened to date, or to this point in this summit, has been around the ecosystem that's being created for that sort of innovation. And I think Two Bear Capital, Next Frontier Capital, and so on, these new resources that are flooding into the state are an opportunity for young entrepreneurs to start to address some of these emerging challenges.
I would like to follow up on that comment. And again, most of our conversation has been focused primarily on testing. And I'm not opposed to testing. I think that we should test. Again, my feeling is that we should test appropriately. But I think that probably what really, if there's a really good, what we really need an innovative idea is to kind of focus on it. Instead of focusing on identifying those who are sick, is trying to get the public to avoid getting sick. And I know this has been a tune that everyone, the CDC as well as General Surgeon has been kind of singing for long, and I think most of us are probably already tired of hearing that. But truth is the best way the best protection we have, to not get sick and have to suffer the consequences of COVID-19 is to not get sick in the first place. And that's been kind of really challenging. And this is actually one of my concerns. Is what I see here is even though we focus a lot on testing, and it's important, we need to identify those who are actually sick, is that it also gives a false sense of security to many people who are tested negative. And as a kind of, and there's a couple of other things going on is that, yes, and we haven't talked about the sensitivities of certain tests. That means the ability to test the virus, and that based on a lot of different things, not just the limit of detection or the number of thermal cycles required to pick up this virus, but there, how the samples are collected. There's a lot of different factors in it. But we get to that point, those, where a lot of chatter had been focused on testing, but we still have to find ways to get the public to do what we need to do to get them, prevent them from getting infected, so that we don't have to keep focusing on the testing, so to speak, because otherwise, once you get infected, that's you're infected, so it's no going back. But to try to get them to prevent it from to getting infected. The final thing I'll add is we haven't talked about this is vaccines as well as treatments, and and this has been a very big hot topic, so to speak, not just politically, but on a lot of the chatters on the medical literature. No epidemiologists are looking at vaccine in the context that this is the magic bullet. I'm just going to say. We're looking, at best, our hope for the vaccine is that it's just going to be another tool that we're going to use to slow the spread, eventually get to that point of herd immunity. It will not provide the first, having given vaccine the first 6 months is not going to create the herd immunity that we've been kind of led to believe that. That we're all going to become protected and that the disease will go away. Realistically, we're looking at this. If we can get a workable vaccine, that maybe in the next couple of years that we will get this better under control. And that's the hope.
Thank you, Dr. Koo. Thank you, Avery, for facilitating a great conversation. I want to thank all of you as panelists for joining us in the conversation today. Our next session, which will start at 12:10. And hopefully an in-depth conversation with Dr. Blake Wiedenheft and Avery Sonnenberg to carry on some of these concepts and look a little deeper at what it's like to be on the front line of innovation and research and development in the face of COVID. Obviously, there's some great conversation about what science can do and maybe some call out for us to expand our sphere of conversation to not just scientists, but communication and marketing experts to figure out how do we take the body of knowledge we're developing and really communicate effectively to the population about how to adopt the kinds of behaviors that will protect them and protect all of us as we try to move forward. Thanks for joining us, and we'll see you in 10 minutes.